Hello, well, I'm delighted to be joined by Professor Anthony Woolf, who many of you may know was one of the authors of the Global Burden of Disease report in the Lancet a few years ago. But he's also an honorary professor at Exeter Medical School and the Peninsula Medical School down in the West Country here in the UK. I first met Tony on the WFC delegation to the World Health Assembly in Geneva a few years ago. And Tony is also chair of Armour, the Arthritis and Musculoskeletal Alliance, of which I'm also a trustee. And Armour's role is to promote the best MSK care available. So Tony, welcome, and thank you very much for agreeing to talk to us.
Thank you, Matthew.
So first of all, perhaps you might like to touch on a bit more about Armour's role and what Armour's been doing through this COVID crisis in particular.
Well, as you're aware, musculoskeletal conditions are a broad range of issues ranging from fractures and injuries, back pain, inflammatory arthritis, childhood conditions, and the professions involved in it and patient organizations are very heterogeneous. But collectively, it's an enormous problem. And if we want to get more action and more done, we have to bring things together. So you alluded to the Global Burden of Disease project. And what we managed to do in that was to get them to look at musculoskeletal as a whole. And in that way, we are able to show it is the greatest cause of disability worldwide. But also, if we want to deal with this, we need to bring all the players together and actually get some consensus about what it is we want and what is best for people with these conditions and preventing them happening in the first place. So the aim of Armour is to bring together all the professional and patient organizations relevant to the area. So we have much greater strength in our voice. So it's one message, many voices. Obviously, we all have different interests within that, but that can be accommodated, but we have to get it over that parapet where it actually gets recognized as an important issue.
And I think you touched on an interesting point there, that there are competing interests within the diverse range of professions and indeed patient groups within Armour, and that's reflected through the healthcare landscape generally. So how do you see integration of the professional groups occurring, and what's chiropractic's role in that? What's the role of chiropractors in that integration?
Well, start off straight away by saying everyone has a key role. I think one thing we have to recognize is that we are all very tribal and we have our own self-interests, and it is always a challenge to bring people together to a common goal, at the same time accommodating people's individual interests. And also, unfortunately, over the last few years, there's been a lot more polarization in politics and other things. And I think COVID and people working more isolated hasn't helped either. So we really have to look for what is that common aspiration, the common goal we want to achieve. And having worked for several decades of trying to get all these different players together, and still keeping my hair, it is focusing about what is it we're trying to achieve. And it's about the public, the person with this condition. How do we make sure they get the best outcomes and the same outcomes wherever they are in a country, in a continent, in the world? And it's trying to get that, get rid of any inequities and getting the right care at the right place at the right time, delivered by the right person. And recognizing, these conditions affect virtually everyone at some point in their lives. We just do not have a big enough workforce. So we have to think of how we actually get everyone fully engaged and have a triaged, pyramidal approach of who's going to deal with the very common conditions, and then the next level up and the next level up. And then you'll need some experts in the more specific conditions, not only to help with their management, but also to push forward the frontiers of knowledge. If we didn't have, at the moment, have very specific experts in genetics and virology and whatever, we wouldn't be where we are at with testing and vaccines, etc. So we still need those, but you then need the troops down at the bottom, the vaccinators, to be delivering it. So we have to look at what are all our competencies and to actually fit into that jigsaw and recognize. And so in my work, I try and get away from who someone is, but what competencies do they have? And by knowing the training that chiropractors have, or the training that physiotherapists have, or podiatrists have, one can see how they can all very easily fit in. It needs to go a bit lateral, and we need to get rid of some of the protectionism that people have about who does what. We did some work in Africa a few years ago where there is a total lack of therapists, occupational therapists and physiotherapists, and most of the clinicians don't know the difference either as to what they do, sadly. And we sort of say, well, why can't there be a generic therapist? And the therapist decide, is it a more physiotherapy intervention needed or a more occupational-like intervention needed? And so we have to be flexible. And I think chiropractors fit in extremely well into that model, because we're in the UK, we're now talking about first contact practitioners. And I was involved in developing the core capabilities recommended for those first contact practitioners. And we very carefully got away from saying who they had to be. Yeah. It was all about their capabilities. And it was then up to each profession or each individual to show they had those capabilities, and then they can do the job.
Yeah. This sort of conversation has been going on for quite some time now. I remember the 2006 NHS, or the Department of Health, musculoskeletal framework, which said pretty much the same sort of thing, looking at competencies and different roles, including chiropractors, in the provision of MSK care, particularly for back pain. And of course, we've had 2 rounds of NICE guidelines since then, both of which recommend manual therapy for low back pain. But not much seems to have changed in the UK. And I suspect the same is true around the world. What do you think needs to happen in order for those recommendations and the ideas that you articulate so well? What needs to happen in order for chiropractors and other manual therapists to be included within that first contact practitioner role?
Yes, and thank you for reminding me, because I was involved in that framework back then as well. And yes, it is frustrating, the amount of treacle in the system for getting change to happen. And the trouble is, because we've inherited a very formal structure. It's a bit like in medicine, we have physicians and surgeons. And I always remember as a junior doctor feeling that a lot of surgical patients would be much better looked after if they were in the medical ward and the surgeon just came in and out doing their operation. But we are very entrenched into these pillars in the system. And unfortunately, in that system, some bits got left out and are on the side. And so until starting to work with yourself and others in your profession, I had no idea what chiropractors did, apart from some probably inherent prejudices about, alternative approaches, etc. And so I think we've got to really, firstly, make sure everyone really knows and respects each other's abilities. In one part of the country, I was involved in helping redesign their spinal pain pathway. And even, the physiotherapists who were involved in multidisciplinary teams with the surgeons and the neurologists, whatever, felt that their abilities were not recognized and they were sort of on the periphery. So I think it's very much somehow trying to get it so that we all sit around the table, like we do at the Armour board, and we forget about, who we are, where we come from. We're all there in our own rights, and there's no hierarchy in the system. I think in the UK, there is a good opportunity for change brought about by COVID, sadly. But what has happened is, as you know, and I think this is worldwide, there's an enormous backlog of people not getting any care, let alone the right care. And there is also a workforce crisis as well. So I think it's really forcing everyone to look at all aspects of the workforce and think imaginatively. And I know the model of care, so I think it's also very much getting models of care right. And I've been involved in the back pain models of care which have been developed by the WFC. That model of care looks at the patient pathway and then really thinks about all the different people who can contribute along the way and what capabilities are needed. And then you and your colleagues really highlighting that you have those capabilities and that we understand exactly the capabilities you have. It's like for this conversation we're having, I asked to have a look at some of your curricula to get a better feel for it, and it's extremely thorough and just as good as I would expect for anyone working in the musculoskeletal field. But I don't think enough people elsewhere are aware of that. So I think it's promoting. The title of your is promoting chiropractors and chiropractic profession, but I think particularly the capabilities you have. And I think the reassurance that people do understand how to triage, how to do a differential diagnosis. And it's only when you come to the treatment bit that there may be differences in what is done.
And it's certainly one of the things that we've been working extensively towards in the Society for Promoting Chiropractic Education. As you say, it's in the name. And one of the things we identified is that chiropractors train in isolation, largely in isolation. So two of the new university courses that we've started are very much more integrated into the training of other health professionals, so that chiropractic students are training alongside others. And that hopefully will inculcate a collaborative approach which will last their whole professional careers. I think there's often been a certain prejudice amongst chiropractors as well about working in the medical community, and that must change too. So I totally
absolutely. And I know, as you said, where I am, we had a new medical school, Peninsula Medical School, and there was a focus on doing more integrated training with the nursing school and the medical school. And I think we do need to do that for quite a long. I've also been heavily involved in making recommendations for rheumatology training, etc., at a European level and global level. And there I've long proposed we should have a common trunk, which surgeons, physicians, physiotherapists all do. Because as I said, it's really only when it comes down to the interventions we use where there's differences. But I know the orthopedic surgeon should understand the basic management of osteoarthritis. And I should understand more about surgery because I'm referring them to them, etc. So I think we do need to get that common trunk as much as possible. And because as you said, one of the key things, I think the value we have is all around integrated person-centered care. And to integrate, you have to bring all the different providers together. We used to have a rheumatology unit where I worked in Cornwall, an 18-bedded dedicated unit with physiotherapy, occupational therapy, even a social worker, all working together. And we would have ward rounds or team meetings, etc. And we were able to deliver pretty good integrated approach to patient care. We then moved to the acute hospital and we just got a ward and all the different therapists went into their own departments, nominally attached to us, and it just broke that that model down, because yes, we technically had a physiotherapist, but it was back down to sort of more of a referral approach, rather than actually all working together and discussing together the problem. So I think we do need to work out how to get team meeting, and it may be trying to get chiropractors more involved in local multidisciplinary team meetings and things like that to try and get there, because once you're around the table, then you can show that you do have those competencies and you do know what you're talking about and what you're doing. And it just builds that sort of relationship.
Yeah, exactly. And how do you think chiropractic undergraduate education should evolve to address those concerns that you've articulated?
Well, ideally, they should feel they're doing just one of the healthcare training options. they're not doing something different. It's it should just be one of the options. I'm doing nursing, I'm doing physiotherapy, or I'm doing chiropractic. It should be as normalized as possible, and mirroring the sort, as you said, if you can't integrate, at least mirror, so people are coming out with the same sort of concepts, same sort of understandings, etc. Because what we want, because it's important that they can communicate and discuss things in the same sort of way. For example, I'm involved, as you might be aware, in the International Classification of Diseases and all the codings and things. And that's where you start seeing different terminologies coming up to what we use and what sometimes gets used in describing some physical skeletal abnormalities. And it's just trying to get that understanding of, what does a locked pelvis mean?
Well, exactly. I mean, that is a conversation that has been going on in chiropractic circles for millennia.
Yeah, and I think if we feel so I'm going to be sort of critical, if we feel there's some mumbo-jumbo we don't understand, that sort of instantly justifies people thinking, oh, it's different.
No, absolutely. I think chiropractors, especially historically, have excelled at mumbo jumbo, and using common terminology is absolutely key to integration.
Yeah, and it's actually convincing us that there needs to be a description of it, because I totally agree. Quite a long time ago, I did a project with someone in primary care from Norway, and he was very against us naming musculoskeletal conditions. So we came up with a compromise of saying, well, there are musculoskeletal problems, which are symptomatic definitions, and there's musculoskeletal conditions, which are more pathological entities. But because we have to recognize that in our area, there's many things which we don't know the cause of, and it would be inappropriate to give them a firm sort of disease label, and a disadvantage to patients.
Well, that's right. And I think bringing patients back into it is absolutely key. I think the disparity between the way different professions describe the same thing is confusing to patients and gets in the way of their care. And obviously, they don't like it when professionals seem to disagree, when in fact, you and I know that actually they're talking about the same thing.
It's a classic, because I would talk about non-specific mechanical back pain without going to be more specific. And then the patient will come back and tell me that he saw the chiropractor who said it was a third one down on the left, which was out of place. And I obviously didn't know what was going on.
I know. It's
it's just trying to get that understood.
Yes, exactly. And hopefully we can address that. And I think working together in multidisciplinary teams is key. But at the moment, in the UK, I think we've got somewhere around 200 different regions, CCGs, something like that. And I think fewer than 10% have chiropractors involved. What needs to happen?
Well, you've gone.
What needs to happen in order to get chiropractors to the table?
So I think at the moment in the UK, we are going into these integrated care organizations. I think that's the current name, but basically it's about cooperation and collaboration rather than competition. That's the jargon behind it. And I think that is an opportunity, because I recently did meet up with some people locally from the commissioning group who are looking at their pathway for lower limb pain. And they are thinking more laterally about how to provide the right care and how to provide different people who can do different things. Because previously, when we were in a more competitive system between primary and secondary care and where the money went and whatever, they would not come and speak to me because I was in secondary care, and they were worried that I would be saying everyone has to come to hospital and be treated in the hospital, etc., without realizing, no, I was wanting to improve the pathway. So I think the pathway at the moment, all too often, someone goes in, has a back pain, and they go into a maze, and it's random where they happen to go and what gets done to them. And it is a maze because it's a blind end, because quite often, the surgeon might say, you don't need an operation, but won't actually say what you do need. And we've got to linearize it and make sure that we are feeding in along the way, and again, argue the case. So I think there's a lot of back pain pathways, and it's actually when it comes to implementing them, because I'm sure in the NICE guidelines, as you said, there's those opportunities of highlighting that, you do have the ability to deliver many of the interventions that are recommended. And it's really, I think, negotiating at that local, regional level when they're thinking about how to improve their pathways, because we've very much set the scene that a lot of the current pathways are inefficient. And that means inefficient in not getting good outcomes, but also wasting resources, inefficiently using resources. So there's a saving from just getting it right. And one of the barriers has been that in our compartmentalized approach, it may be that all the money is in the back surgery budget, which is in secondary care institute X, and it needs to be out in the community, but actually the mechanism of shifting the money isn't there. So I hope that the new system we're going into will make it much easier to make sure that resources can be, the funding, which is the bottom line that one needs, can be shifted into the right place to pay for the right services. But I think at the moment, it's just to really highlight in all the pathways how your competencies match against what is needed, the interventions needed and recommended.
And once chiropractors have mapped out those competencies, where should they go? Who should they contact? Who should they approach?
This is where I lose track of who is actually but I think it is the commissioning groups or whoever is taking over the commissioning groups. I know that the National Clinical Director for MSK in the UK is recognizing that there needs to be local leads and getting local plans sorted out. And I think it's very much being in there, highlighting. And I think the other thing to recognize is that we are, for a lot of our conditions, we're trying to move much more towards self-management and public health type measures, lifestyle measures, etc. So I think it's very important that you yourselves are fully embracing that, and that's part of the management plan. So, because I think the downside of manual interventions sometimes is that it has to be not repeated. And I think showing that there's also proactivity in trying to make it more sustained benefits and more lasting benefits. So I think highlighting the amount of patient education and lifestyle recommendations and social prescribing and things like that, because those are all the sort of underlying policies of how to manage these conditions. And then on top of that, we add more specific interventions.
That highlights a very good point, because I think chiropractors have sometimes been guilty of providing a monotherapy, just manipulation. That is changing. I think a lot of chiropractors are very well aware of the exercise rehabilitation side of things and integrate that far better. And also chiropractors have often given lifestyle advice and so forth, but that's often not something that chiropractors talk about, because the special thing that chiropractors do is the manipulation, and they want to talk about that. But in fact, it's the whole package of care which is the important bit.
Yes, it needs to be a spinal pain management program, not, as you say, a monotherapy and come back for another monotherapy.
Yes, exactly.
Because that does give a tarnished reputation of when because we know, for example, spa therapy, used to happen in the UK, still happens in some parts of the continent, But again, one of the issues was the cost effectiveness, just because of the sustainability of it. But they've had to also adopt more of a rehabilitation sort of philosophy, rather than just being a nice 3 weeks in a spa. Which,
well, that sounds delightful.
Absolutely.
We all need that at this time of year.
Lovely. But, as we know, is beneficial, but doesn't have long-term benefit for the investment in it.
Yeah. Well, Tony, thank you very much indeed. Is there anything else you want to add before we finish up?
No, well, I think we need, just to emphasize, we all need to be working together still, because at the moment we are beginning to get more traction, recognizing the importance of physical function, physical fitness, the importance of musculoskeletal health, the threat to that of all these different conditions and the need for better treatments. And we've got to take advantage of that opportunity now to get it on the agenda. And I'm also working globally with your colleagues, globally still, trying to get it on the World Health Organization's agenda. And I think we're beginning to get some traction, but we do need to get across how we're working in a joined up way in this, as we've said, making sure people get what is best for them to maintain their health and maintain their independence.
Well, I think that is a perfect point to finish. That is focus on the patient, which is why we're all here after all. So Professor Anthony Woolf, thank you very much for your time today, and good luck on integrating all those different professions in your work around the world.
Thank you.